Hi, my name is Steve Pantilat. I'm a professor of clinical medicine at UCSF and the director of the Palliative Care program. Let me start talking to you about palliative care by giving you really the single most important take-home point about palliative care. And that is a definition of what palliative care is. And let me start by telling you, in fact, what palliative care is not. Palliative care is not end-of-life care. What is palliative care? Palliative care is care focused on improving quality of life for people with serious illness. That's what I want you to remember as we talk about palliative care in this, which is the first of 4 modules focused on palliative care. In this module, we're going to talk about what palliative care is, give a definition, tell you a little bit of the evidence about why palliative care is so important for patients, and set up the next 3 modules and the content area that we'll talk about together. We need to take a step back, though, and really first talk about medical care for the seriously ill. And the challenge here is that it is poor value, which is to say that 25% of Medicare spending each year is for the 5% of people who die. So a tremendous amount of spending for a small group of patients. But if you think about it, that in and of itself is not a problem. High costs in the last year of life are to be expected. Each of us should be our sickest in the last year of life and will likely consume more health care in that year than we will in any other year of our life. So that fact in and of itself is really not the problem. The problem is this, that despite high spending, the quality of care is poor. And by that, I mean people receive care they do not want and from which they will not benefit and cannot benefit, and they fail to receive care that they do want from which they will benefit. And because we see this, that people are getting care they don't want and not getting the kind of care they do want, we see that this spending, rather than making people better, is in fact adding to their suffering as they deal with serious illness and as they approach the end of life. Now, most lectures, most presentations, most modules that you'll hear about are trying to convince you of why this topic is so important. And so this module is no different. So let me begin here by telling you that death is very common. In fact, there are over 2.5 million deaths a year in the United States, and that number is increasing as the population grows. And yet, life expectancy at birth in the United States is excellent. It's about 80 years and getting longer, slightly longer for women than for men. But despite that statistic, what we know is that everybody will die one day. And the leading causes of death are heart disease, cancer, lower respiratory conditions, and stroke. These are the illnesses that we died of as Americans 50 years ago. They are still what we die of today and what we live with for a long period of time. Now, to be clear, the treatments we have and that we offer patients make their quality of life much better and allow them to live longer with their serious illness. But ultimately, each patient will die. And so the question for us is, as healthcare professionals, how can we provide the best quality of life to our patients while they're living with serious illness and as they approach the end of life? You may have heard people talk about, oh, we have to help our patients achieve a good death. That's the goal, a good death. But what I like to say is, the only good death is someone else's. That ultimately, it's not about achieving a good death, because death is always going to be sad, it's going to be filled with grief and loss. Our goal, in fact, is to help people achieve a better life with serious illness and a better death than they would have had if we had not been involved at all. And that's the focus of the care that we want to provide, and that's the focus of these modules. So I want you to imagine for a moment the end of your life. Where are you? Who are you with? What does it look like? So did you imagine this? This scene for you or your loved ones at the end of your life? An ICU. Not the UCSF ICU, but certainly could have been. And what do we notice here? So you can see the person on the left lying in bed is alone, lots of monitors, tubes going in and out. The person on the right at least is not alone. Someone's at the bedside, a doctor, a nurse, maybe it's a respiratory therapist. but what we know is that this is not what we'd want for ourselves or for any of our loved ones. And yet we know that 1 in 5 Americans today dies in a hospital that included an ICU stay. And so the question for us is, how can we make things different for patients who don't want to end up this way? Now, you might be thinking to yourself, well, people do legitimately end up in the ICU, and that is true. Many people come to our hospital hoping that we will make them better. They are desperately ill. They end up in the ICU. And unfortunately, our treatments cannot make them better. And then they are too sick to leave the ICU. And that is a challenge for us as well. How do we make this environment more peaceful, more comfortable for patients and their families? But for most patients, you can see it coming from a mile away. They've been admitted to the hospital multiple times, perhaps even to the ICU, and here they are going to end up again in the ICU, this time not making it out. How do we prevent that from happening for people who don't want it to happen? One way to do that is to make sure that we talk with our patients about what they want to have happen to them when they get sick like this. And in Module 2, we'll focus on communication and the ways we talk with patients to help them make these decisions. So what is palliative care? I've been talking about it, but I haven't given you a definition. So let me give you a definition now. This definition was developed by the Center to Advance Palliative Care, and it was based on market research, which is to say they went out to people, Americans, and said, here's what palliative care is about. Which of these things really resonate for you? The idea being that we wanted to create a definition that really resonated for people, because what you'll find is that people do not know what palliative care is. If you do a palliative care rotation, for example, and tell your family and friends that's what you're doing, they may look at you with a blank stare, not knowing what you're talking about. Now, I would say that's a good thing because people don't have a bad impression of palliative care, but it's also a challenge because they have no impression of palliative care. So let me share with you some of the language, the definition and language that I like to use with patients at the bedside, in talking with people and in talking with colleagues about palliative care. And that is that palliative care is specialized medical care for people with serious illness. This type of care is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a team of doctors, nurses, and other specialists who work with a patient's other doctors to provide an extra layer of support. Palliative care is appropriate at any age and at any stage in a serious illness and can be provided together with curative treatment. Now, to be fair, that is a mouthful, and I don't say all of this at the bedside because that would take up the entire consult with the patient. So we don't have time for that. But let me highlight a few things that are very important and that really do resonate for patients. And the first is this, that palliative care is for people with serious illness. And we'll talk about that more in a moment, but it is not end-of-life care. It's for people with serious illness. And the good thing about that is that people can really relate to having a serious illness. Heart failure is serious. Cancer is serious. It says nothing about how serious. It says nothing about death or dying. It just talks about serious illness. And as we'll talk a bit later, we'll see that people with serious illness do have a lot of symptoms. In our next module, we'll talk about that. And we'll see that serious illness is a good construct for how to think about palliative care. It is for relief from the symptoms, pain, and stress of a serious illness. Anyone who has been sick or has had a loved one who is sick knows that serious illness has pain, other symptoms, and stress. People want help to relieve that stress, and palliative care focuses on that. But perhaps the single most important part of this definition is right here. The focus is to improve quality of life. Abraham Lincoln said, it's not the years in your life, but the life in your years that matters. And whether we measure life in years, or months, or weeks, or sometimes even days or hours, the focus is how can we help people have the best possible quality of life for as long as possible. The last part of this definition I want you to remember is palliative care offers an extra layer of support. It's in addition to all the other care you get, not instead of, and an extra layer of support. And who, when they are sick, doesn't think that they might benefit from an extra layer of support? Keep this definition in mind when you're taking care of patients and as you move through your career. It is the definition of palliative care that most resonates with patients and demonstrates what the benefits are. So here's a picture of what this model of palliative care looks like. It's called concurrent palliative care, which is to say you get palliative care alongside curative care. So how does this work? Let me tell you a story that really highlights this model of palliative care. Patient of mine, primary care patient of mine, 89 years old, really quite healthy, a little bit of high blood pressure, a little bit of hyperlipidemia, married, lived at home with his wife, still driving. One morning, I get a call from his wife that he has left hip pain that is so severe that he can't get out of bed. So I tell her to call an ambulance, bring him to the emergency room so we can evaluate. So they bring him to the emergency room and we are worried that he has a hip fracture. He gets an x-ray, but the x-ray is normal, no hip fracture. But he's still having significant pain in his left hip, and so they decide to go ahead and get a CT scan. And as is customary with the CT scan, they get a few cuts above and below the area of interest, and above they go through the liver and they find 2 masses that are suspicious for cancer. They arrange for him to have an ultrasound-guided biopsy, which he has done, and the biopsy shows that he has cancer, colon cancer, now metastatic to the liver. So I had arranged for him to come and see me the day after the results were available, and he comes in with his wife and his son. We sit down in my office, and I have to share with him this really bad and unexpected news that in fact was unrelated to his hip pain, which had gotten better. And so we sit down, and I say, Mr. Smith, I'm really sorry to have to tell you this, but the biopsy showed that you have cancer, colon cancer that has spread to the liver. And immediately, Mr. Jones had 2 questions for me. Can you imagine, think for yourself for a moment what those questions were? So his first question was, am I going to die? And his second question was, how long do I have? And that's not uncommon. Many people, when they hear this kind of news, go to those questions first, because that's what they worry about right away. I would submit to you that responding to those questions is in the realm of palliative care. The expertise for how to respond to that is in palliative care. Now, that's not to say that any doctor, nurse, social worker, chaplain shouldn't be able to respond to that question. We all need to know how to respond, but the expertise is really in palliative care. So that's what we had to talk about first. Is he going to die? He was going to die from this disease. It was likely going to be the disease that would take his life. How long did he have? It was very interesting that over the course of our conversation, he thought he was going to die in 2 or 3 weeks. Somehow his impression was, when you get diagnosed with cancer, you die really soon, just in a couple of weeks. So our conversation about his prognosis, which was really about a year long, in many ways was good news for him and better than he expected. I did refer him to an oncologist. He did receive chemotherapy, at which point we had a bigger focus on curative care. Now, the chemotherapy made him pretty sick, and so we had then a bigger focus on palliative care. What this slide shows us, though, is that over time, either because the patient is no longer interested in it or because it's no longer available, palliative care begins to play a larger and larger role in the care of the patient. Yes, sometimes there's more focus on cure, sometimes more on palliation, but over time, palliation may occupy more and more of the focus of care up until the time of death. But what this also shows us down in this corner here is that even on the day of death, patients may still be pursuing curative intent treatment, which is to say, for example, people with heart failure, who even on the day of death are taking their ACE inhibitor, their spironolactone, their beta blocker, their Lasix, as well as taking their morphine for pain and shortness of breath. This line represents hospice. Hospice is a wonderful service for people with a 6-month prognosis, generally provided at home. I'm not going to say a lot more about hospice, except that the one thing I hear from patients and families is, when I refer them to hospice, is, gosh, I wish I'd been referred sooner. So always think of hospice for your patients with serious illness, particularly as they get sicker and more homebound. If you look at the orange part here, it reminds us also that we play a role in bereavement. This is not just about the patient, but also to remember that the family becomes our patient, and we have to think about them in bereavement. What this also shows us is that while bereavement gets better generally within 6 months, the most acute part of bereavement does get better. And if it persists beyond that, we have to worry that perhaps someone is having complicated grief. This tale reminds us that we never get over the death of a loved one. And you may hear people say, oh, don't worry, you'll get over it. No one gets over it. We always remember. And I like to ask my patients who've had a loss, what are you thinking about your wife today, rather than are you, because we know that they think about them every day. I like to say that this is the best possible quality of life for as long as possible. That's our goal with patients. And if we follow this model of care, that's what we can promise to them. So what is the evidence that this actually makes a difference? If we follow this model of getting curative intent treatment at the same time as palliative care, does it make a difference? And the answer is yes, it makes a big difference. Let me give you a study that demonstrates this. And this is a study, a randomized controlled trial done at Harvard, at Massachusetts General Hospital. They took patients who presented with metastatic non-small cell lung cancer. So just to remind us all, that is a non-curable disease at the time of diagnosis. Okay, there's chemotherapy that is helpful in helping people live longer, but that is not a curable disease. All those patients at Mass General received chemotherapy, standard chemotherapy at Harvard, which is apparently very good cancer care. You know, it's not UCSF, but pretty good. Half those patients then were randomized to receive palliative care at the same time. Palliative care provided according to the definition I gave you by qualified physicians and nurses. So what happened? Well, the short answer is everything good you want to have happen to a patient happened to the people who were randomized to palliative care, which is to say they had superior outcomes when they were randomized to receive palliative care. They reported a better quality of life, improved symptoms. They had less pain, less dyspnea, less nausea. They had less depression. They were less likely to receive aggressive care at the end of life, which is to say they were less likely to end up in the ICU, to get chemotherapy in the last month of life, or to have a code. And very importantly, they had longer life by 2.7 months on average. The survival in the palliative care group was 11.6 months versus only 8.9 months in the usual care group. A tremendous improvement in longevity, as well as an improvement in symptoms. What we can say is that that improvement is as good or better than the chemotherapy they received, and shows us that if we pursue this kind of care, concurrent care, palliative care and chemotherapy, we can help our patients in every way that is important to them and to us as providers of that care. Is that care available to everybody with lung cancer today? Unfortunately, it's not. I think if this was a pill that you could prescribe, everybody with cancer would be getting it, but it's not. It's a team of doctors, nurses, social workers, and chaplains providing this care, and we still have a ways to go. But here we have evidence that if we can provide this care, we can make a tremendous difference to our patients. So this study was done for people with cancer. But who else is appropriate? What are the other kinds of patients to think about for palliative care? Well, think this way about people who would be appropriate for palliative care. Someone with heart failure or COPD, second admission in a year. That's about a 50% prognosis at 1 year for people with heart failure. Breast cancer and a malignant pleural effusion. Someone with metastatic lung cancer, like in this trial. Anyone with dementia and aspiration pneumonia. Someone with cirrhosis, second admission for altered mental status. Someone awaiting solid organ transplant, because we know that most of those people, unfortunately, will not receive an organ and will die from their organ failure. Another way to think of it is to ask yourself this question. Would I be surprised if this patient died in the next year? When we ask ourselves this question, we all can come up with patients where we say, you know what? I wouldn't be surprised. I would be sad if this patient died, but I wouldn't be surprised. Turns out that's a pretty good prognostic sign, and has been demonstrated in studies to be a good way to identify patients who would be appropriate for palliative care. So when you see your patients in the clinic, in the office, in the hospital, at home, think to yourself, would I be surprised? And if the answer is no, think about what are the palliative care needs this patient has and how can I address them? Do they need a consult from a palliative care team? So what is it that patients want when it comes to palliative care? Well, it's really three things. They want palliation of symptoms. That's what they tell us. I don't want to be in pain. I don't want to be short of breath. They say, I want clear communication about what's going to happen to me and help with making decisions. And they say, I want psychosocial support. Well, all right, they don't actually say I want psychosocial support. What they say is, who will take care of me? Where will I be cared for? What will it be like? Because these are the areas that are important to patients. These are the three areas we're going to focus on in subsequent modules and look at each issue one by one in the coming modules. So what's the take-home points here? Palliative care is medical care focused on promoting quality of life for people living with serious illness. That's the single most important take-home point. And palliative care should be provided alongside any other appropriate treatment. It's not instead of any treatment, but it's alongside other treatments in a way that helps patients achieve the best possible quality of life for as long as possible. Thanks very much.